So my name is Rachel Jackmantonio, and I am the Knowledge Translation Coordinator with the Maritime Spore Support Unit and your host this afternoon. If you're not familiar with the MSSU, we're one of 11 spore support units across Canada that support and conduct patient-oriented research, which means that we're involving people with lived experience directly in health research. And we work in all 3 maritime provinces. I'd like to start by offering a land acknowledgement that reflects my location here in Chibouctouc, or Halifax. I want to acknowledge that I'm in Mi'kmaq and that this is the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which Mi'kmaq and Wolastoqiyik people first signed with the British Crown in 1725, and we are all treaty people. I also want to recognize the histories, contributions, and legacies of the African Nova Scotian people who have been here for the last 400 years. And I know that some of you may be joining from other parts of Mi'kmaq or other parts of the country even. And so I'd like to invite you to take a moment to reflect and add a land acknowledgement to the chat if you feel so inspired to share the lands where you live and learn. And before we dive into the session, just a few obligatory housekeeping notes. I think these are familiar to most, so I'll go quickly through these. Please mute your microphone. We are recording the session, so that will be available on the MSSU YouTube channel afterwards. Closed captioning is enabled, so you can turn those on in your settings. And if you have questions throughout, feel free to type them in the chat. Sometimes it's a little hard to see raised hands, so just include your name alongside your question if you'd like to come on camera and ask, or on audio and ask. Okay, so I'm very pleased to welcome you all to the latest Learning Health Systems in Action webinar. And so the term Learning Health Systems, or LHSs, if you've heard the acronym, can be a bit confusing or might be new to some of you. And so I wanted to open with a definition. This one is from the Agency for Healthcare Research and Quality. And they say that in a learning health, internal data and experience are systematically integrated with external evidence, and that knowledge is put into practice. As a result, patients get higher quality, safer, more efficient care, and healthcare delivery organizations become better places to work. And it's a little bit wordy, but what I like about the definition is this connection between the process of generating evidence, learning from it, and having an impact on the outcomes that matter to patients and the health system. And so this is not the only definition of an LHS, but really across a lot of these different definitions and models that you might encounter, there's a shared focus on generating and applying evidence in medical practice. And so as a result, the elements of a learning health system are often visualized as a learning cycle. This is ours that we've developed at the MSSU. The graphic is on our website if you want to take a look. But really what you can see is it's a simplified way of thinking about how these various components of a learning cycle feed into each other. So you have data that's generated, it's integrated with external evidence, and then used to generate new knowledge that can be applied to policy and practice, and then this cycle continues. Given our patient-oriented research roots, in our model, we put community at the heart of this process, and to reflect our values and health system aims with an overarching commitment to equitable care. The cycles themselves and lots of the LHS models are very flexible, so they could be applied at different levels in the health system. For example, an entire health authority, networks of facilities, a hospital, a specific unit, or a program. And maybe you recognize aspects of your own work in an LHS approach, even if it's called something else. And that's what this series is really all about. With these webinars, we're trying to get to know the cycle. And in each session, we zoom in on an element of the learning cycle and try to bring it to life with an example of how it can work in practice. And so I'm really pleased today. We're going to be looking at different ways that knowledge is generated and applied within a learning health system with a really fantastic example, the public health mobile units in Nova Scotia, and we'll look at how they're using evidence to inform their evolution. And so I'm going to keep the introduction short to keep time for our speakers, but first we'll be hearing from Louise Hanavan, who is a public engagement advisor with Nova Scotia Health. She's going to introduce engagement for those that are less familiar with it and really highlight the importance of values and principles in this work. And then Holly Gillis, who is the director of the Public Health Mobile Unit, or PHMU for short, is going to demonstrate how the unit is continuously learning from staff, patients, and communities. And finally, Louise will bring us full circle and share how an engagement process helped to inform that evolution. So we're going to try to do all of that in 30 minutes, even though it's a lot to cover. Louise is smiling. We'll see how we get on. And hopefully have some time for questions and answers at the end. So without further ado, I will pass things over to Louise to get us started.
Great, thanks so much, Rachel. So yeah, as you've already introduced, my name is Louise Hanavan. I work as an engagement advisor with Nova Scotia Health. So it was interesting just to see at the center of that learning health systems model, community is at the heart of a learning health system, and public engagement is really about how do we bring community into the decisions and planning that we do as an organization. So we can move to the next slide, and I'll just give you an overview of what Holly and I are going to talk through today and what we hope you'll get out of it. So we're going to talk about engagement in general at Nova Scotia Health, how we're set up, and then Holly will share the story of the Public Health Mobile Unit starting from 2020 and carrying on into its evolution now. We are going to talk about creating and applying evidence from engagement and evaluation into practice for the Public Health Mobile Unit, and then we'll offer some resources to learn more about engagement and the Public Health Mobile Unit. So I'm just starting us off with a definition of engagement. So when we talk about engagement at Nova Scotia Health, we're talking about sort of a very specific definition of engagement, because you've probably heard about like social media engagement, or engagement just means having a conversation with somebody. And in our case, we're talking about something a little bit more intentional. So we're talking about the process that we take on with the purpose of working in inclusive and respectful ways to shape decisions, actions, impacts, or change. And so this is a definition that's used by the International Association for Public Participation, IAP2. And engagement in this case is purposeful, it's goal-driven, it's based on trust and relationships. It's values-based and people-centered. It's oriented towards impacts and outcomes. And it's also inclusive and centered around equity. So this is the definition that we've adopted within Nova Scotia Health, and it's an internationally recognized definition of engagement. We can move to the next slide. So our public engagement team at Nova Scotia Health helps our organization build capacity around incorporating public and patient feedback into decisions and action planning. So that's across all kinds of teams within Nova Scotia Health. So we're offering training sessions, we're coaching team conversations and helping people build engagement plans. We're developing resources for use within the organization. So we offer those tools and resources, and at the end of the presentation today, we'll share a link to our resource page. And then we sort of help guide people through the engagement planning process. And we do have an engagement policy within Nova Scotia Health, just outlining our adoption of the definition, and then also putting some tangible things into place of what that means for expectations and accountability for leaders and teams within the organization to be doing engagement on an ongoing basis. And also the community connections piece, just recognizing that there's a lot of variety in the relationships that any given team within Nova Scotia Health holds. We are a small team, but we do try to spend some time just directly in communities where those relationships might be lacking within the organization, so that we can sort of steward on relationships with communities over time on behalf of the organization, and have some connections to start with when we begin an engagement process. So for Nova Scotia Health, really, like, engagement is in our policy. It's a foundational piece of all the work that we do, and it's what enables the dialogue with the public, the patients, families, and our community partners that we work with. And we can move to the next slide. I'm just going to share with you this values-aligned approach. And so IAP2 has its own set of values, and this is not dissimilar, but this is specifically that we've developed within Nova Scotia Health because it matches our values as an organization and tries to articulate how our work in engagement helps us live our values as an organization. So really, the reason for grounding any of our engagement work in values is that when we go into community to have conversations, that reads to people of what is our intention, and are we doing engagement to check a box, or are we doing it because we truly value what communities have to offer, and people's autonomy over their own health experiences. So the first one here is respect. And so to us, that's about welcoming the experience and knowledge and understanding the needs of people that we serve, and using that to inform and enhance our directions and actions. The second one is integrity. So that's being transparent with information, honest in our dialogue, and sincere in our commitment to involve others. In the value of courage, it really means reflecting in ourselves of, like, can we be open to really learning and hearing feedback even when it's hard to hear? So it does take courage to invite others in and accept their experience as an opportunity to be better. Innovation, so definitely hearing outside perspectives always helps us innovate, and our willingness to take on those perspectives and embrace new ideas helps us live that value. And of course, accountability. Engagement is about trust building, and it relies on trust. So involving people is part of building that trust and recognizing that all of us really, the health system is owned by all of us, and all of us are part of creating solutions, and really have the wisdom to be able to collectively have that wisdom to be able to improve health systems. So we can move to the next slide. I just want to share one more little tool that we offer to our teams, because sort of the most harmful thing that we can do is go out and ask a question that we're not actually ready to hear the answer to. And so when we're working with teams, these are just some reflection questions that we use to start people off. One of them is, I am comfortable questioning the impact of my program or services engagement activities. I believe that together, clients, families, communities, staff, and clinicians can look beyond their own experiences and sometimes their own, like, professional training to come up with practical ideas and solutions. And the third one, which is so hard in health, because this is a culture of training, like so much academic training and so much credentialing. And so to truly believe that the voice of clients and families and communities are equally important to staff and clinicians in planning and decision making. That's a big ask of somebody who's spent 15 years training to recognize themselves as the expert. And so um, just taking a moment to feel like, am I really ready to hear from people? So um, I think I'm excited for Holly to share her story. And I think in this story, we're going to have a chance to hear, like, you'll be able to see how some of this readiness on her team allowed them to hear from people and respond in ways that allowed for really exciting innovation and learning. Um, and we can move to the next slide because I'm going to ask you all as you're listening, um, maybe noting down on the side, um, how do you see these values or personal readiness um, as enabling factors in the work that the public health mobile units have been doing? Um, so I'll check back in at the end and you'll have a chance to share your answers. So I will plop these values into the chat here and you can take notes as you listen, and I'll pass it over to Holly.
Great. Thank you, Louise. Over the next few slides, we're going to be traveling back in time a little bit to 2020. And I want to recognize that reaching back into the COVID pandemic time, it might evoke different responses, different feelings, different reactions for all of us. So just a reminder to take care of you, do what you need to do to be present, lean into what recharges you if you go back in time a bit, and what refuels you as you move through the session. The other piece I want to start by recognizing is just an acknowledgement to everybody on the webinar right now who either worked in the pandemic, supported public health measures, or contributed in some way, and a thank you for helping to keep Nova Scotia and our communities really healthy. This is not my work I'm sharing. This is the work of people who have contributed on the public health mobile unit team, both present day and in the past. And I'm just today and share the story and the experience with you. Next slide. So this is where it started and where it began. So the foundation of engagement as a key to learning and knowing our work in healthcare was really important for us to pay attention to as we moved into it. And back to the public health mobile unit evolution. It began in the summer of 2020. We received a federal grant to support mobile outreach testing. We were starting to recognize in public health some barriers to people getting tested for COVID. And in the fall, the mobile unit initiative was initiated as a provincial support to help Nova Scotia's COVID-19 provincial testing strategy. So the work involved the development of the vans, the development of the equipment, staffing and processes to deliver COVID-19 services in a provincial model in communities throughout Nova Scotia. Initially, we focused on COVID PCR testing and evolved to rapid testing to communities in the province that were experiencing COVID-19 outbreaks or in areas where testing was not otherwise easily accessible through Nova Scotia Health, our careways, our pathways, our infrastructure, or where we were. And we really were developed to provide that rapid service and flexibility in our COVID-19 response. And when we started the planning and figuring things out, the community and the system support was really at the heart of the work, which is a really important core of engagement and learning for us. And when we started to look back in time, we found the picture you see on the top left of the screen that there used to be public health involved in mobile health, doing mobile X-ray services and helping tuberculosis way back in 1948. And so we took a little bit of that inspiration as we moved into jurisdictional scans, assembling a team and building the leadership. Next slide. So here's a picture of history in the making. It's the first public health team at our very first public health mobile clinic at the beginning of December 2020. And this picture really highlights learning in action for me. We had to rapidly do the work, learn how to figure it out, set up, tear down, and do it better the next time. We were engaging with the health system for the design, the delivery, the implementation, listening to the feedback constantly. There was a lot of conversations in that parking lot with principals of the school on how we deliver our service, how we show up as public health, and the pace was unlike nothing I've ever worked in before. We were recruiting people to do the work without being able to fully describe the work to them at times. The elements that Rachel mentioned in the opening really align with the cycle we were on in public health. There was components connecting, integrating, pulling through the knowledge, learning, and sharing back ways of practicing and support for the people that were doing the work and the people that we were serving in Nova Scotia. We were constantly thinking about community. We were constantly thinking about the staff. We were thinking about the brand of public health and the impact we wanted to have with people. And being equitable and providing that access was a really core function for us. Equity for rural Nova Scotians, for people who were underserved, or communities that needed different ways of public health showing up. Next slide. So what was and what became the Public Health Mobile Unit? And I'm thinking there's probably even a few people on the call today who work or have worked in the Public Health Mobile Unit. From the beginning, the concept of mobile units for Nova Scotia Health involved a lot of internal engagement. We were going to areas that were doing COVID testing and trying to figure out how to do it using vans in a team and community in a different way. Building the program really necessitated us talking to other people formally and informally, looking at who was doing it, how were they doing it, and how could we learn, figuring out everything from the signage to the pylon you see in the picture. We really paid attention to was client patient focus and thinking about the whole health experience and learning, reflecting, and doing it better the next day. We built a responsive team to bring public health to community, and we're still learning and growing the elements we need for a mobile workforce in Nova Scotia. Next slide. So ways of learning has been integral and continues to be part of the way we implement and evolve our program. We are a bit of a system within many other systems that deliver healthcare in communities across Nova Scotia. And as part of the public health program, we're continuing to evolve work and thinking about what do we do in regular public health work. And over the next few slides, we'll travel back together through the various ways the mobile unit team has been learning, thinking about innovation, and integrating those elements into our work. So the next slide. Part of public health work is about going to people. It's about supporting outbreaks and really trying to provide different considerations for different elements that were showing up that we needed to adjust, pay attention to, and deliver service. Some of the settings and the populations in the communities we served during the COVID response are there on the slide. And if you think about those groups and what you might envision with them, no one size fits all approach is absolutely had to work. We had to respond in a way that was useful to public health, giving back information, doing testing, and also helpful and supportive to the community. Oftentimes in 2020, 2021, requests would be made and we'd be asking to mobilize in a different community or geography within 24 hours or less. Next slide. This is one of the ways that we use data and learning for program implementation. As a new public health mobile program, we needed to determine where to deliver service. Sometimes outbreaks led us to our work, and sometimes we had to figure out where to go. When testing wasn't being directed by an outbreak response, we wanted to support communities who needed access in different ways. We were still really working hard to contain the virus. So how we reached locations was using available data and information as best we could. We were using rapid reviews for mobile health, talking to other people who were doing testing, talking to other parts of the health system working in community. We have an organization in Nova Scotia around geographic clusters and worked with our index basing information on demographics, health status, recent COVID-19 activity, and where there was already testing access. For instance, it didn't make sense for us to set up beside a hospital in the community if that hospital already had testing on site being available and provided. So to determine geographic location, we were thinking about an equity approach, the epidemiology. Where was there a venue available? At that point, there may have been different public health measures. So getting a Legion or a community hall might not be easy. And really trying to inform how we did evidence-based clinic locations as best we could. All of our supplies are transported on the van, as well as some of our staff. And sometimes we're doing services on the van or in nearby buildings or in parking lots. We wanted to make evidence-informed decisions as best as we could to be accountable for the investments that were made in public health. Next slide. And as we evolved, we looked at different ways of knowing and deciding where to send the public health mobile units for service planning. So you can see a reference on this slide back to some of the other ways of knowing that we highlighted. We were looking at lots of different pieces and trying to put it together. And then next slide. After we started to use our EPI index in our planning report, we could add in that community context and look at different changes and look at where COVID activity was showing up. It's constantly learning from our work, the community around us, the system, and using feedback to figure out where to go next. Next slide. We are trying to become an agile and a responsive system around making decisions to figure out where we needed to go. We had staff teams that were working one day, not quite sure where they would be the next. We tried to get a longer planning runway as best we could to let folks know where we were going so community and others could plan to come to our service. We looked at different ways of knowing to inform the decisions that we could around where we had to show up. Next slide. And this is an example of how we were able to use our EPI index and our public health planning report to think about showing up with our COVID-19 clinics. So relevant in this context means that the clinics occurred in a way after we used the data within about a 3-week period to show where we could be and where we could show up. Next slide. So we were also doing some non-targeted mobile unit community clinics as we worked through the pandemic and the virus evolved. These were community clinics. Testing availability was criteria was different, but our approaches stayed really similar. We were trying to hold public health clinics in friendly, non-clinical environments to increase the trust for those who may have experienced discrimination or had a negative experience in a medical environment. Really wanted to provide low barrier access to testing, so we had drop-in models. We provided rapid tests. We weren't doing screening at various points. We were identifying and building relationships with local leaders who could support or promote or endorse public health. In some spots, we used community volunteers to support the greeting, the flow, asking clients to change into a mask instead of using uniformed security. We would test people in their cars or their parking lot, a practice that continues today, along with our vaccines as requested. And that might be to mobility, discomfort in clinic spaces, or a client preference. We prioritize clinic spaces that were physically accessible and supported clients in different ways. That might mean completing report and support, an online web form that was used to identify clients at risk of severe disease and facilitate access to therapeutics. We also provided transportation support to reduce the barriers to where folks needed to go for testing. And this is a nice aerial shot of one of our community clinics in Eastern Zone. Next slide. Another piece that we added into our ways of knowing was asking clients for feedback as they were leaving our clinic or our service. And we do continue to capture these experiences when they're doing the work. We want to hear the voices of the people we're serving to do it better. And this practice, as mentioned, continues today. Really have to give kudos to the staff as part of this client experience. They do the work. Whoever does the work is as important as what the work is. It really takes unique people to work in a mobile workforce where no 2 days are the same, where you may not know where you're going next week, where you may wake up, think you're going one spot, and then you turn around and you're going to another spot. And the accountability, respect, and integrity to the work and to community really comes out in our team. And you can see a few feedback pieces from our clients, as well as a few pictures of our team in action. Next slide. So there's a lot on this slide. You'll have to zoom in and read through the infographic, and we'll give you the link to where you can visit the evaluation report. But this is a one-pager that really talks about where we landed through our formal evaluation. We wanted to learn from the experience. We didn't know what the future would like or what the sustainability of the mobile unit program was. We wanted to capture the lessons learned, and one of those key themes was communication and engagement that helped us be successful. The evaluation also revealed our approaches and some facilitators that contributed to our success. We embraced an iterative and resilient approach. We applied a health equity lens. We had strong leadership support. We were innovative, tolerated risk, engaged community, leveraged the community support, collaborated, and built partnerships that are facilitators that continue to make the mobile unit successful. I love that we continue to go back to some of the communities we were in 2021, in 2025 in a different way. We also were continuing to learn on the daily. We had to work hard to ensure clear documentation, manage our documents, manage our content from the beginning, built reported evaluation and feedback into our program planning, whether that was a short planning cycle or a longer one. Really important to have access to timely data, something we continue to strive to receive in public health today. The workforce and the leadership is key. You need the right people for the right roles to do this work. This work isn't for everybody. It's not for folks who like a repetitive and a consistent approach to their workday. It's for folks that can work in a very different way. It's also important to ask for help early and often across the system. Next slide. So we started with testing in 2020, and we evolved to meet the current needs of what was asked for us by the health system and public health. So you can see here a few areas that we expanded on. The expansion included direction and engagement within and across the system. It included hearing gaps from community, hearing of experiences that worked or didn't, and showing up in a bit of a different way. Next slide. One of the pieces we were also called into support was some public health emergency preparedness and health system response. That includes things like Hurricane Fiona, some photos you see on the slide here, supporting with the health system wildfire response, floods, and snow events as they occur in community. Next slide. So what did we do? A few of the numbers we want to highlight for you over the past 4.5 years that we've been in service. We've completed a large amount of community clinics. Each of those involves coming in, setting up, tearing down, usually in the same day or over a couple of days. We reached close to 100,000 PCR tests. We also went to over 260 homes to support people with having a test completed, distributed millions of rapid tests, supported tens of thousands of immunizations, and continued to support outbreaks and emergencies apart from COVID through our work. Next slide. So thinking back to the slide at the beginning, what were some of our lessons learned? Lots that can fit on this slide and fit on slides to come, and folks that have worked the mobile unit could also share with you. Really had to pay attention to prioritization and resource allocation. We've never been a really large team. We've had to prioritize our resources based on the data and based on community needs. We had to build the infrastructure, the logistical support. There's a small and mighty group of less than 5 people that make decisions and provide consistency around where we need to go and how we need to get there. It's really essential for the effective functioning, including everything from location selection to how did that location go. We've been integrating the mobile units within the broader Nova Scotia health system where we can, looking at streamlining processes, avoiding duplication, and looking for effective coordination. One of the earliest wins that took us about 18 months to figure out is we aren't mechanics in health, but Department of Transportation and Nova Scotia government is. So we partner with them for vehicle maintenance, supplies. They have great garages across the province, things that we don't need to build in healthcare, but we can lean into. We had lots of staffing changes. People were sometimes in and out of the work. I'm excited when we're starting to reach some milestones of many months of people being in the work. We wanted to provide, ensure staff safety, that people had a good working environment, that they were challenged and successful in their work. We want to make sure we're attracting people and retaining people in the health system. We have to appreciate the balance between public health and the other health system partners, where there's collaboration and where there are other parts of the system that can provide primary care and other pieces. And we're constantly in that communication and engagement learning cycle. So early, clear, ongoing communication to let people know that we're coming out to community to build that trust, and to do education about what we can and can't do as a public health system. Next slide. In 2022, Action for Health was launched as Nova Scotia Health Strategic Plan for the healthcare system. And we've been able to really look at the 6 solutions that government's calling on us to do and think about how we're showing up in our work, and pay attention to the lessons learned and our evolution with the strategic plan to make sure we are also part of the solutions and actioning health improvements for Nova Scotia. So I'll turn it now over to Louise.
Great, thank you. Yeah, so at this juncture in the public health mobile unit, their team recognized that, you know, there would be some kind of transition where those public health mobile units might be used for something else, might move into a different part of the organization. And they recognize an opportunity to do some engagement, both with staff within Nova Scotia Health, but also with government partners, community partners, and members of the public. So Jeff Wilson, who's the director for public engagement with Nova Scotia Health, took a lead alongside Holly in developing an engagement plan to determine what was next for the mobile units. So some of the questions that they wanted to ask were, where do the mobile units best fit within the public health structure? What kind of options are there for future use? Are there additional uses that might be on the horizon for those mobile units? And then as they were defining the project, they thought, okay, we're not actually looking for mobile health recommendations for Nova Scotia Health as a whole. We're not looking for recommendations about workforce. And this is not the conversation where we're debriefing on the COVID response from public health. So with those things in mind, here is the engagement plan that they developed. We can flip to the next slide. So they ended up with 6 focus groups across the province. So they spoke with staff, Nova Scotia Health and IWK staff, government staff, and then there were also some conversations with community organizations and members of the public. And then put together a survey on the Engage for Health platform, which is now a shared online engagement tool between the Department of Health and Wellness in Nova Scotia, Nova Scotia Health, and IWK. And so it's basically a hosting site for surveys and other kinds of online conversations. And so a bunch of data was gathered through that as well. And this project was a collaboration between our engagement team and the public health mobile unit team. And so we can flip to the next slide. We're not going to go through the recommendations that came out of that process, but the report and the site where community partners and participants would have been part of that engagement process is still live online. It's at engageforhealth.ca/public health mobile unit with little dashes in between the words, and you can use that QR code. Next slide.
So what's next for the public health mobile unit? So we have, we formalized transformation priorities in March of 2024. And public health mobile unit is one of the areas of transformation, which means we're determining a model the focus and the goals for the work. In April of 2024, we were established with funding as a new provincial public health program. We finalized the COVID services work in June 2024 and began rebuilding a new phase. New team members were recruited and new work began in the fall of 2024. And these are the areas of work that we are continuing to work in: testing services, immunization, and public health emergency preparedness. Throughout all of the work, we try to do health and social support system navigation. That means directing people with any of the questions they have. No door is the wrong door, and helping people access the information or learn about something that they might not know about. We pay attention to equity, and partnerships are key throughout all the work we do as we try to go to where other people are not. Next slide. Here are a few samples of our public-facing promotions and our work with community. There's different ways we work with people and that we invite people in to do the work. At the bottom middle, you'll see a poster for a slide at a big mall in Dartmouth, really trying out some different space for public health. We're not used to setting up clinics in the malls, but it's great to be side by side with Sephora, and you get lots of different conversations with families as they're walking around the mall. The top middle is a poster that was developed in partnership with our Black Health and Wellness community members as we work to bring over 18 clinics in the way that made sense for them through the fall and winter to the communities. And so a bit of a different poster for a different look. At the bottom left is a clinic at the Halifax Public Library site. The site had to shift and there was people wanting to get vaccinated. The team adapted. They moved forward with doing the on-van vaccination and delivering the work. It was a much colder day than the picture shows, minus double digits, but they finished off and got everybody vaccinated that wanted to be serviced that day. So looking ahead, we're constantly listening, we're learning, we're building. We're really excited to be invited here today. Thank you to Rachel and Claire and the team to share our story of engagement and ways of learning in the public health mobile unit.
Awesome. I forgot to say when we showed this slide first, like why is there a gift there? And it's because when you share your answer to this question that we posed at the beginning, you can be entered into a draw to win some fun swag from the public health mobile units. So what we'll ask folks to do now is just reflecting on what Holly shared and the process that the public health mobile units have developed to be able to inform their process on an ongoing basis and be in relationship with the public. How have you seen these values or personal readiness show up in the work that they've done? So in the chat, you can share an example of any one of those things. And if you don't mind also including your email address alongside your example, we'll go through, Rachel offered to go through afterwards and do a draw of names, and we'll connect with the winners to send out some little gifts afterwards.
Thanks, Louise, and thanks, Holly. I really appreciate you being here today and sharing your experiences with the Public Health Mobile Unit. It boggles my mind to see how many different ways the unit is learning from staff, from community, from health system data, and so on, and just that overarching commitment. I can see so many examples of ways that those values are coming out in the work, not just in how you approach broader engagement and system partners, but your staff as well. So that's really wonderful. And we'll leave this slide with the values up for a minute, and they're at the top of the chat as well. So as Louise said, feel free to drop a specific example in your email if you want to win some PHMU swag. In the meantime, we'll use the time that's left for questions. So if anyone has questions that they'd like to ask, please feel free to drop them in the chat. You can put your name on. I'll try to change my view to see any hands if they go up. Give people a second to think about it. Maybe everyone's thinking about the values. So I'll start us off with a question. I think One of the things that really stood out to me, Holly, you mentioned earlier about that kind of community comes across, but you also talked about the pace of the work, right? And I think sometimes we hear a lot like, how do we reconcile needing to move quickly with engaging? And you also made that comment about how you love that you're showing up in the same communities in 2025, but maybe in different ways. And I wondered if there was a relationship there between the ability to work quickly and kind of develop those relationships long term. And I see Louise nodding too, so maybe I'll give it to Holly first, and then Louise, if you want to hop in as well.
Great question. And the pace did require us to work very differently. We had to, as a team, be okay with taking risks, to recognize, the supports we needed, whether it was leadership or trust or the ability to work in, what we now call a little bit more formal test and try. So how we set up in December 2020, there's some elements that look really different in January, February 2025. But we, paying attention to consistent core elements around really customer service, communication, respect in all that we do, whether we were getting it right or we were getting it wrong. Can't overstate the value of relationships, which are also equally as important as processes. We were building the processes while we were carrying out the relationships that the community needed. And that required a lot of flexibility and adaptability, a lot of good faith and courage to try things out, to recognize when we didn't get it right and do better the next time for sure. And I think because we were showing up and we did start to build trust or relationship, people did call us back or reach back out to us for other services, or we've made those connections that we can take into another time or another relationship as we need to.
Yeah. Yeah, I think those are all amazing points. And I love how talking and conversation came up so often in the presentation. It feels like making space for that is so important. Louise, did you want to add anything to that point about the relationships?
No, I was just nodding along because I think you're so spot on in identifying that as just being such an incredible strength of the approach to this work.
Yeah.
I think there is also a piece of appreciation from communities when healthcare or services can show up in their communities. There's a lot of reading we did around, ironically, bookmobiles and how when we were getting started, like the impact they have in communities when they go to places that may not have a physical library but can bring that service. And I think in healthcare, being able to go and do it from a safe way where a spot people may be used to, that's familiar for them, makes it a little less scary for them to get that COVID test or a vaccine or work through a hesitancy. There's a lady who will always stay with me from a clinic in New Minas in 2021, and we were on the main drag in New Minas. I think there's only one main drag, but we were at the Legion, which is also the bingo hall, which is also the fire hall. And we were there doing COVID testing. And my job for that day was I was outside thanking people, opening the door, giving out little pocket hand warmers because it was really cold and we had people outside waiting that day. And sometimes people waited 2 hours for a COVID test because of the uncertainty around the virus at the time and where we were at. And she was leaving and she thanked me for being there in community. Her husband had died the previous year in one of our Nova Scotia health hospitals, and she had wanted to get a COVID test. Her family had been asking her for a couple of days, but she was too scared to go back into a hospital. And somebody said we were at the bingo hall, so she took a drive down. And that's, I think, part of how we can show up differently, and be okay with it may not be, the exact site we want, but we adapt it as best we can to meet people where we're at. So that's one of the pieces that's forever important to me in this work.
Thank you for sharing that story, Holly. I mean, I think that's such a powerful illustration about that showing up for people where they are. And I think it brings to mind another question we talked about before the session, which is just how does equity show up in your everyday work? And I mean, I think part of meeting people where they are is really caring about what experiences they're bringing to how the health system has served or not served them in the past, how their kind of interactions with them have impacted them, and making sure that the service is provided in a safe and accessible way. So I think that's a fantastic story to illustrate some of that.
Yeah, equity is vital to us in healthcare, and I think we sometimes use the words without recognizing the power of using the processes to support the words. So, and sometimes we are working with different populations. So maybe a group of First Nation community leaders or folks from Black communities, and really following their lead of what they wanted us to pay attention to and to do. You know, that might be participating in town halls with a medical officer of health and then figuring out afterwards how we show up in that community, or it may be building that relationship with not really an ask, but being ready to respond if they did come to us. And that was one of the tricky pieces, was then you have to be able to follow through on fitting in those requests when people were ready. We are working right now on a rapid health equity impact assessment, looking at where we can pay attention to our immunization work for the years ahead. But constantly trying to use elements of equity lens in our planning and our service delivery.
That's fantastic. And I'll pick your brain about that rapid health equity impact assessment. That sounds very interesting. But I see that there's a few questions that have come in the chat, and I want to make some time for those. And just to let you know, we've had a lot of great points raised around the values as well. So I will save the chat for you guys and share them afterwards if we don't get time to kind of read them all out. The first question, though, comes from Tina Price, and she's asking, in the early setup days, were you able to connect with folks operating mobile health clinics in other provinces for their lessons learned and for support? And she gives some examples: Montreal, Winnipeg, Victoria, and BC.
We did. So we absolutely reached out. We did a really rapid jurisdictional scan, and we did a very tight short turnaround time literature review looking at things. It was mostly a lot of gray and formal literature that we learned from, but we did talk to people that were operating vans, including in, the North End Community Center in Halifax. Our mobile outreach street health team has had a van and been running a van. They were gracious and shared their van with us for us to look at and to talk with staff. In 2020, fall of 2020, everybody working in health was really busy. So oftentimes those conversations were at night, late at night, replying to emails. We reached out to some spots in America that were doing mobile health, and continue to try to keep our pulse on what's happening out there, what's evolving, looking to, visit other mobile health vans and clinics before we purchase new vans. But our vans are starting to get 4 to 5 years old, so we do have to start to think about sustainability and turnover and what might we do differently. Different climates have different considerations. It gets really cold here in Nova Scotia winters, so having something like a hand washing station on a van wouldn't work for us. It would freeze, for a good 4 to 5 months of the year. So trying to figure out different models and different ways of working. But we're constantly looking, and if you have any connects with any programs, we'd love to reach out and talk to folks. We're constantly looking for learning.
Great, thanks, Holly. Before I go to Amy's question, just a comment from Donna, and coming from Donna, I think it's especially high praise. She says, as a patient, this is what patient-centered care looks like: system designed around patient and community needs. So I just wanted to make sure that got shared in plenary. Our next question is from Amy. She is asking, she says, great presentation, really impactful work. Two-part question. First, how do you identify all the data sources needed to inform your decisions about where to place units? Do you think it's easier to use data to inform decision-making? maybe we'll just do the first question first. I always lose track of things when I say both out loud. So the first one was about identifying the data sources needed to inform decisions about where to place the unit. So I think that's going back to the outbreak response piece you were talking about, Holly.
So in the, it varied depending on the year and the month of what was going on. Certainly at times we were directed by medical officers of health or our health protection teams about, needing to go set up a testing in community X, or we were seeing some early warnings of increasing COVID cases or activity. We also were using constantly looking at access points. So where might there be availability Monday to Friday, but maybe there wasn't weekend access in a community like Liverpool. So there was a lot of looking at service and operations and then figuring out where to be. We were also, as we started to roll out, people would reach out to us or suggest communities. And depending on what the testing strategy was or the availability, we would visit those communities if we could, or look at different things. Now we're looking at, where is their immunization access? Where is their immunization coverage rates? How much are people able to get vaccinated by maybe other service providers like pharmacies? Who has a primary care provider? Where are there gaps in primary care provision? And also really important, we keep, as a team, we work evenings, weekends, not a typical Monday to Friday 8 to 4 schedule. So that sometimes equity or access is also just providing, a late afternoon, evening, few hours of service, or Saturday or Sunday for people to visit us to get their vaccination, or in the spring of last year, pick up a COVID test. So we really are variable in what we're doing. We're looking at things like material deprivation or social deprivation and trying to think about what communities might need us a little bit more, even if they can't identify that as a need.
Fantastic. Thanks, Holly. And the second part of Amy's question was, do you think it's easier to use data to inform decision-making and adaptations for a new service, like when the PHMEU is coming online, or an existing service that kind of changing midstream? And she's asking mainly in terms of behavior change or responsivity of staff administration to making changes.
A really interesting question. It's almost one I want to take to the staff and ask their input and the team. The gift of being a new program was there was no expectations other than delivering service. So being able to be responsive, to be agile, to set up, we were able to build our indicators and our impressions and our work as we went. Definitely, when we were thinking about recruitment for permanent workforce, we did highlight the agility required, the responsiveness required, that people will be expected to travel on vans and travel to different locations, that we have 12-hour shifts, that we have evenings and weekends. So trying to be really visible about what people were signing up for. And I give huge kudos to all the team members who have worked on or continue to work with us, because we have a bit of a blank space. We're still filling in what our future model is in our program. And they've signed up for it, knowing it will be public health work in community with some of the conditions. And we are still learning what are the elements of a mobile health workforce we want to pay attention to. Folks are driving longer. They're working in different with different people and in different settings. So how do we pay attention to that going forward are things we have to figure out as a team together.
Yeah, I really like that element of building kind of a culture to the work, I think, with the people. Maybe I'm hearing that a bit in the orientation.
Absolutely.
And your comment earlier about whoever does the work is as important as the work. It reminded me in the policy space, sometimes people talk about people are the policy, because it's sort of how you enact it that
Absolutely.
brings it to life. And I think that's a really wonderful kind of way to wrap things up, since we're now at 1. I just want to thank you again, Holly and Louise, for joining us, and give you a moment to add any final thoughts, if you'd like, to the discussion. Although I see you're both muted, so I'm thinking maybe we're feeling pretty tired now. There is a link. Oh, sorry, Louise, go ahead.
Yeah, I just wanted to say to you, like, thank you for putting this together. And I think this is one among so many great stories to tell. And really in the learning health system space, I think it's all about concrete examples and stories. And I think the public health mobile unit was a great choice, and one that Nova Scotia Health can really be proud of in terms of best practices for engagement.
Absolutely. So thank you both for coming along and sharing that story with us today. And to everyone who stayed and come on the journey and shared this story with us, I really appreciate your participation. There is a link to an evaluation survey in the chat. Please send us your thoughts. I mean, learning is kind of our theme, and we'd love to learn from your experience of the presentation. I'll also send a follow-up email, and that will have some of the links that we had up on screen today as well. So you'll be able to get to some of those resources and more information about the unit. And just thanks again for joining us. Have a good afternoon, everyone.
Thank you, everyone.
Okay. Thanks again, Holly and Louise.